Good evening, ladies and gentlemen. I'm Jatinder Bali, and it gives me great pleasure to welcome all of you to this National Skill Transfer Initiative webinar. This is a basic series webinar, and today we will be talking about optimizing outcomes in trabeculectomy and the current and the emerging paradigms, the alternate and the mainstream paradigms in glaucoma surgery. And we have with us very eminent personalities, including the we have the chief guest, Professor Dr. Tetyal. Then we have Professor Kirti Singh. We also have with us Dr. Rakesh Shakya, Dr. Prachi, Dr. Shweta, and our moderators for the evening today are Dr. John Davis Akkara. He's a glaucoma, cataract, and refractive surgeon in the Western Eye Hospital in Chaitanya Hospital in Kochi. He was formerly the Faculty of Ophthalmology at Sri Ramchandra Medical College, Chennai, and he was the glaucoma consultant at Little Flower Hospital. He completed his MS from JIPMER, his glaucoma fellowship from Aravind, and he has completed the Ratan Tata Advanced Cataract Fellowship from the Shankar Nethralaya. He is an eminent personality and a faculty at AIUS, Asia Pacific, APVRS, KSOS, TNOA, GSI, the Cochin Society, and he's more well known for his virtual reality, perimetry, smartphone, ophthalmic imaging, virtual reality, Raspberry Pi based surgical recorder, 3D printed glaucoma valves, smartphone apps, and other innovations that he's done. He has also publications in ophthalmology, in artificial intelligence, 3D printing, and so on. And our second moderator for the evening is Professor Rajwinder Kaur from the Adesh Medical College at Bathinda. And she is the managing editor of the Adesh Journal of the Adesh University. She is executive member of POS and the Women Ophthalmology Society, ISMSICS. And she's been the winner of the best free paper of WOS in 2017, of WOS in 2020 in retina challenging cases, the IGO Platinum Award for being the co-author in Cosmic Study. And she has various publications and index journals and a special interest in glaucoma. So without further ado, I'll hand you over to Dr. Rajwinder and Dr. John. Over to you, ma'am.
I will introduce Dr. Jatinder Bali. He is the chairman of International Research Committee, International Society of Manual Small Incision Cataract Surgeons. He is the chairman of DOS Subcommittee for Information Technology, Practice Automation, and Clinical Informatics. He is the library officer, Delhi Ophthalmological Society. He is the associate editor of Global Journal of Cataract Surgery and Research in Ophthalmology. He is the chief editor of 1 Minute Ophthalmology. Authors of Basics of Biostats, a manual of medical practitioners, Basics of Glaucoma, Pathological Ocular Angiogenesis, and Macular Edema in Diabetes. Aakhari Virasat, That Night Was the Sweetest, and the Sanctimonious Subterfuge.
Next, I will introduce our chief guest, none other than Professor Jeevan Tetyal. Professor Jeevan Tetyal does not need an introduction, but here goes. He is the chief and professor of RP Center for Ophthalmic Sciences, All India Institute, Delhi. And he has more than 400 publications and more than 3,500 citations, 6 books and more than 60 chapters. He has delivered more than 50 orations and keynote addresses, numerous live surgical demonstrations, and regularly conducts instruction courses in AAO, ASCRS, ESCRS, APAO, APSRS, and you name it, all the international conferences. He has 2 patents, and he has won several international awards and honors, such as the Distinguished Service Award at APAO 2021, Senior Achievement Award and Achievement Awards at American Academy and Asia Pacific, APACRS Certified Educator Award, and he is also the first Indian to perform live surgery in ASCRS in the USA. He has several national awards. He is Padma Shri by the President of India in 2014. He has won the P. Shiva Reddy International Award in AOS 2021-2022, R.P. Danda Award, AOS 2020 and 21, and 4 gold medals. He has held several positions, including the President of the Indian Society for Cornea and Correctorefractive Surgeons, 2016 to current. He is a chairman, National Eye Bank, RP Center, AIM, 2020 to 2021. That's a long time. President of DOS 2013 to 2014 and Secretary DOS 2003 2005. There are many things to talk about him, but well, due to lack of time, let's continue. Thank you. Over to you, Dr. Rajwin.
Our first speaker is Dr. Rakesh Shakya. He is the Chief Consultant and Head of Department of Glaucoma, Senior Consultant Cataract and IOL Services, Sadhguru Netra Chikitsalya, Shri Guru Seva Singh Trust, Jhakikot, Chitrakoot, Satna, Madhya Pradesh. In professional qualification, he has done MS Ophthalmology from SS Medical College, Rewa, Madhya Pradesh, MP. And he has done comprehensive fellowship in ophthalmology, fellowship in glaucoma and cataract, short-term fellowship in glaucoma and cataract from the Moorfields, London. Surgical proficiency and experience, he has done more than 1 lakh cataract surgeries and 15,000 glaucoma and other surgeries. And he is expert small incision cataracts simulator reviewer, Amsterdam and Netherlands. He has done so many research and academic activities that is trained 100 ophthalmologists in glaucoma and cataract, certified faculty for postgraduate course, faculty and chief advisor for paramedical courses in ICO fellowship programs. He has given more than 50 instruction course and faculty talks at international, national and state level conferences. He has presented various paper and posters, live surgeries and international achievements, simulator reviewer at Amsterdam, short-term fellowship in glaucoma and cataract surgery, Moorfields, London, and extracurricular activities, documentary film on glaucoma for public awareness, holding positions as treasurer in Divisional Ophthalmological Society, Rewa, at present as joint secretary in Divisional Ophthalmic Society, Rewa, and ICMS Madhya Pradesh, MP chapter. He's a member of AIUS, GSIA, MPA SOS, and since 10 years. He will speak on FACO-TRAB, the tips and tricks. Over to you, sir.
You can't
I am unsharing my screen.
Yeah. Please stop your screen. So my screen is visible?
Yes, sir.
Visible, sir.
Yes, yes.
Yes, sir.
So good evening to respected J.S. Tetial sir and dear friends, especially Dr. Jitendra Bali and all. So I'm going to talk about the FACO-TRAB with FACO with trabeculectomy. So as you all know, the association with the glaucoma and cataract has been the more frequent because the increase the life expectancy and the increase the risk of the cataract development in the patient with the glaucoma. The combined procedure is consider the visually significant cataract and the uncontrolled glaucoma on the maximum medication. So, according to the collaborative normal tension glaucoma study, they found that the rate of the cataract formation was actually 48% in those treated with the trabeculectomy. According to the advanced imaging glaucoma study, they found that the 78% increase the risk of the cataract following the trabeculectomy. And according to the collaborated initial glaucoma treatment study, the rate of the cataract surgery was 3 times greater in the surgical group. So, what are the indication about the FACO-TRAB? It is combined surgery. It is the patient with the uncontrolled or marginally uncontrolled glaucoma with maximum tolerant medication therapy, along with visual significant cataract and patient inconvenience and visual impairment the cataract. And the questioning cataract, when the patient come with the cataract and glaucoma, so we have the three options: cataract surgery alone, combined, and the two-stage technique. So the phacotabaclectomy, we can do the one side or two side, and the conjunctival flap, as you all know, this is the limbal based or corneal based, and the conjunctival flap are equally effective in improving the visual acuity and lowering intraocular pressure. So this is the my surgical video. So my video is actually running. My video is running.
Yes, sir. We can
Started,
see
yeah.
the
Now it
video.
has started,
Yes.
yeah.
Yeah. So initially, I always take the corneal traction suture. It is about the 0.5 mm away from the limbus, and then I cut the conjunctiva with the Weisskott seizure. It is about the 6 mm, and then undermine it. It is about the 7 mm or and more than that. And this is the very important step because the conjunctival peritomy or advanced conjunctival actually advancement is very important because when you actually hold the conjunctiva with the sharp instrument, you can cause the trauma. And after that, we do the bedfold cautery and then put the mitomycin C sponges. It is the multiple sponges and the subconjunctival space. So after that, we remove it and then count them always, because sometimes that this sponge remain. So you always count before putting, and then thorough wash is done with the help of saline, and it is about the 30 ml solution. So after that, we always mark it. So I always make a flap. It is about 4 into 4 mm. And then after we make a two side fold and then put the visco and deepen the chamber. After that, we make a triangle flap, and with the help of the crescent, it advanced into the cornea. So it is very important to the flap. This the partial thickness scleral flap should be very uniform plane, and then it is go up to just 0.5 mm into the cornea, and then just mark it and put the visco, and with the help of the keraton, we entered into the antechamber. It is the 2.8 keraton, and deepen the chamber and make a circular exit, which is about 5 mm, 5.5 mm. Because the cataract is the grade 3, so 5.5 mm is sufficient. So after that, we do the multiple hydro dissection in the multiple sites. And always tap it. And after the hydro dissection, we always actually rotate the nucleus, so the nucleus is free from the cortex. And then we make always I follow the stop and stop technique. Initially, after removal of the cortex, and then expose the nucleus and make a slightly deeper trench. So this is the modified stop and stop technique we all follow, and then hold the nucleus and crack it in the multiple pieces. And then emulsify it. And after that, the cortical removal is done. And deepen the chamber with the viscoelastic and close the eye. After the unfolding eye, I always keep the slightly horizontal. Haptic should be horizontal because sometimes the haptic can actually block the ostium. So we keep it the horizontal. and then remove the visco again, and then put the some amount of the pilocarpine. And during the visco removal, we always remove the visco behind the eye also, because in the post-op period it can cause the reactions or sometimes it can cause the high RP. So then after the deepen the chamber, just see the cornice scleral junction and just enter the antechamber. It is just 1 mm away from the this junction, and then cut up to this junction with the help of the caliche punch, and it is about the 0.75 mm. And with the help of the Vanna seizure, we cut the iris, do the iridectomy, and then the removal of the this. And then we put the some amount of the air or saline to see the patency of the ostium. And after that we put the two suture in the arm, the arm of the triangle, and tighten it. And the knot should not be very tight. So after that, we put the one releasable suture in the center, or sometimes in the arm of the triangle. Sometimes we put the 2 or 3 multiple releasable sutures. And then watertight conjunctival closure done. And after the hydro stitch, you can see the bleb is forming. And then always give the subconjunctival DEXA. So this is the first post-op period. This is the picture. Cornea is clear. AC was deep, and the bleb is actually bleb height is very good. And then post-op we do the antibiotic and steroid combination, the taper dose, and a topical atropine 3 times for the 2 weeks, and follow the patient in the 1 day, 7 days, and 30 days, and 2 months, and then every 3 monthly if possible. So advantage of the one side phacotuberculectomy is the less surgical time and lower endothelial loss and less corneal trauma due to the single incision, and readjustment of the surgical position not needed. And the advantage of the two-side phacotrap is the less tissue injury at the bleb area, better IOP control, help in the deep-seated eye and difficult situation, less abdomen and less AGM is required. So according to the Pew study also say that the same results. So that they are actually resulted that the both technique yield the similar result and the consider the final BCB and IRP control. However, the two-side group had the less induced astigmatism, and two-side technique allow the better IRP control at the lower level and with the peer anti-glaucoma medication. So when we compare the TAB versus phacotuberculectomy, so the additional phaco emulsification does not influence the intraocular pressure control in the one eye. This is the 1-year study. And regarding the refractive outcome, these are two studies at the Chang et al. Done the myopic shift prediction error was significantly more frequent following the phaco trap compared with the phaco emulsification alone. And the long-term post-operative effective outcome of phacotrabeculectomy and phacoemulsification alone were not significantly different in the eye with the open-angle glaucoma, regardless of the post-operative axial length. And when you're planning the surgery, so I always follow this rule. Actually, when we plan the cataract alone, when the patient come with the no significant visual field loss or cupping and acceptable IOP control, less than 2 medication, older age, or narrow angles like PSC and PSCS cases and ocular hypertension. And two-stage procedure I always follow. In those cases, very advanced glaucoma or macular threat, or in the difficult glaucoma like active uveitis or neovascular glaucoma. And the combined surgery, I always follow when the patient come with more than two medication, IOP is not controlled, younger age, and high risk or difficult glaucoma, and significant cupping or visual field loss, and unable to tolerate the two separate surgery. And sometimes the patient has some allergy condition, so we follow the combined surgery. So thank you so much. I know correct.
Thank you, Dr. Shakya. Fantastic surgery. So your preferred modality is single site.
No, actually, maximum cases, I always follow the single side. And sometimes in the those cases, we have the high pressure cases, like when the patient come with a more than 30 millimeter Hg intraocular pressure, or sometimes the patient with the angle closure glaucoma. And then on these cases, I always follow the two side. But then 70% cases, I have done the single site.
I take this occasion to welcome Dr.
Many people are used to temporal incisions. They might prefer two side.
Yeah.
Yes, I follow the same school of thought, two side surgeries. But as Dr. Sakya correctly said, that actually it all depends that how comfortable and what is the indication, where, in which kind of eyes you are planning. So
Yes.
that way we can just titrate the sites. Good evening, ma'am.
Welcome, ma'am.
Good evening, ma'am.
Good evening. Sorry, there was a personal issue. Yeah, so wonderful surgery, Dr. Rakesh. And that's a very beautiful video. I joined a little late. And
Thank you.
good
Thank you
evening,
so
Dr.
much.
Tetyal, sir, and everybody. And thank you for having me on this platform. It was lovely.
I always actually listen your talk when I was in GSI. So please, ma'am, I always invite to you, please come to in our institute, Sadhguru Nature Sal in Chitrakoot.
It will be a total pleasure. Chitrakoot, anyway, is a beautiful place from the religious point of view, and you guys have made it such a pilgrimage for ophthalmologists as well. You are doing such terrific work. It will be a total pleasure for me to come there. Anytime.
Thank you.
So a very good invitation and acceptance, both have happened. I think
also we are waiting actually for our conference in the June.
Yeah,
Okay.
I just received the mail. I'll just see if I'm free because I'm traveling to Singapore for some time for APACRS.
Yes.
And from there, I'll see if I can make it. Otherwise, it's my first preference. You know that.
Thank you. Thank you so much.
Good, very nice talk. I think considering the age group of patients and where they do have some sort of a cataract, many people opt for a combined surgeries.
Yeah.
But I'm not sure. I'm not a glaucoma surgeon at all. Well, I did do some phacotraps in my around 20 years back. But now the scenario has changed. Most of the surgeries are combined nowadays. The glaucoma surgeries. If doing a ab externo or ab interno procedure nowadays are all combined with the phaco nowadays. You are doing a bang, other things. You have to do a phaco first. So in fact, the combined surgery has become a norm for most of the disorders. Let it be a cornea cataract or a vitreoretinal cataract. So this has to be done by the people. A properly done cataract surgery along with the trap will decrease the patient's inconvenience. Maybe they are more congenial to your advice also. The only thing which I always thought in my mind is that does the post-op complication rate increases with the combined surgery as compared to the single stage surgery? Because I've seen patients simply trap and they're absolutely flat chamber, very difficult to form the chamber again, multiple reformation happening. So if we do a cataract surgery along with that, would the things make a little more difficult?
So I think, sir, we are actually working in the high volume center. Here, the maximum patient come for the cataract surgery. So this is the coincident. This is the they are the patient not come for the glaucoma. Only the 5% patient come for the glaucoma here. So the 95% patient come for the cataract. So they are actually diagnosed as the advanced glaucoma. In this area, actually, they are the advanced glaucoma is much higher in this area.
Mhm.
Actually,
Yes,
we
yes.
are operating today. Even sir, this is the summer season. Today I operate the 12 phaco travel today.
My
Actually,
God.
so so actually in the winter season they are the about 30, 40 trap per day. Actually, we all operated in the team by the team. So here the patient actually does not come for the follow up. So why this reason actually we admit the patient for the 3 days here. So we operate the patient. First, we actually reduce the IOP and inflammation. Then do the surgery and then admit the patient for the 3 4 days. And when the IOP is actually good and the AC was good and everything was good, then we discharge it. And then
Okay.
try to actually follow the patient in the vision center. But actually in the vision center, it is very difficult to actually do the some examination not very good, but in our institute the patient come follow up only the 1 month or 2 months. After that the follow up rate is very less. But nowadays we are doing the some counseling and they are the multiple the group counseling in this our hospital. So why this reason the follow up rate is slightly increase in our hospital also. So this is the conditions are here.
Sir, actually, most of the time, it's like a incidental, coincidental finding, I should say, the advanced glaucoma with the cataract. And when we see at the CAM patients and the bulk patients, definitely, sir, most of them are landing up into like 0.9 cupping or a phacomorphic or a phacolytic. So we'll end up doing the combined surgeries most of the times. So that is there, sir.
Yes.
So the interesting takeaway, I think, is the group therapies. So that's something which is interesting if it motivates the patients to come back for a follow-up.
Yeah,
Definitely.
we actually do that. We have the three counseling room in the glaucoma. So we do the group counseling. In the ward also, we actually do the group counseling for the follow-up only.
So
Actually,
they
group
come
co-
together
Yeah.
and they go back together, sir. They will come no on the same day, and then they will say that we all have to go together back with the same vehicle. So it is like that, sir. So that is the benefit we are getting with that.
Actually, what I do is I always do for the glaucoma patients, and you're right, Dr. Rakesh. We have in a recently conducted study, we have more than 20% of patients who are coming to us are one-eyed, and one-eyed, and most of them are 0.9 or no rim at all types. Macular split is so common. When people tell me you do macular split, I said we almost always do macular split because that's what the situation is. Now, the way I counsel is from the very beginning, I make the caregiver accountable. And especially if it is a daughter-in-law, I praise her to the skies and I tell her, you're such a nice bahu, or the daughter or the son. आप इतने अच्छे बेटे हैं, आप अपनी माँ को लेके आए या बाप को लेके आए हैं. And one thing I always tell them, for glaucoma, you and me have to be friends for lifelong, or at least for half an hour after your death or my death. That's how I speak to them. You have to be my friends till one of us goes away, because glaucoma is that type of a disease, and you're going to keep coming and see. Like your name is Mohinder Singh, and your son's name is Joginder Singh, and Mr. Joginder, you are going to bring your mother to me or father to me every 6 months, and मैं आपका नाम लिख रही हूँ क्योंकि आप इतने अच्छे बेटे हो. So you give them a positive reinforcement, because for older people it is not easy for them to motivate their only earning child to come and bring them. Remember, at least we deal, and I'm sure you all deal with the people who are little low wage earners. So any chutti the guy has to take, his wages go for that day. So to bring the mother again or the father again is kind of difficult, and these patients. So you just have to counsel them accordingly and call them very minimally. And I agree with you, Pecotrav, we are doing much more frequently for that very reason, because they may not come back to you. And secondly, especially in angle closure glaucoma situations where the lens is bulky and has the volcano configuration, it's always better to have it out. Not clear lens, no way, but not eagle study. I don't agree with that. But the bulky lens concept has come in, and we are seeing it very frequently, and we are doing a lens extraction along with the trab. Yeah.
Thank you, ma'am.
No, why
Thank you.
not clear lens extension in a shallow angle cases?
So it's never, if it is a lens fault. Now we're not focusing on the lens clarity. We are focusing on the lens fault. And if the lens fault is more than 0.91, yes, sure, take out the lens. Clear lens invariably, sir, hota hi nahi. Clear lens is usually above below 50, and by that time AC shallow kabhi nahi hota unless it's nanophthalmic. Nanophthalmic situations are different, or microspherophakia, and that there you'll have a lens bulge and a shallow AC. Otherwise, ACG, primary ACG scenario per se will never cause so much of a shallow unless it's repeated attacks. And in that situation, lens will never be really clear. So I don't agree with the clear lens because, sir, in that concept, moment you're 50, 60, all of our lenses should be out. And no, I don't want my lens to be out. Yeah.
Okay, very nice.
We could, with Professor Titial's permission, we could move to the next speaker, sir.
No, you all are fully permitted because I'm only the listener, you know.
Sure. I will introduce Professor Kirti Singh. So Professor Kirti Singh is a director, professor and director of Guru Nanak Eye Center, MAMC, Delhi. She is graduated from Lady Hardinge Medical College with distinction, best undergraduate student, multiple gold medals, post-graduation from RP Center, fellowship in glaucoma from Wills Eye Hospital, USA, international fellowship in medical education, FAMER 2016, PG diploma in hospital management, National Institute of Health and Family Welfare, faculty of Maulana Azad Medical College from 1997. She is the editor of Delhi Journal of Ophthalmology 2021 to 2023. She has multiple honors. She is appointed Director, GNEC, and Head of Department of Ophthalmology, MAMC, since May 2021. State Program Office, NPCB 2021. National Ophthalmic Lead, Educational Weekly Webinars, NBE. Honorary Faculty, Medical Education Department, MAMC. Honorary Faculty, Microsurgical Skills Training Center, MAMC. Honorary Faculty, Occupational and Environmental Health and Clinical Epidemiological Unit of MAMC. And multiple awards, Commonwealth Fellowship 1999 to 2000, WHO Fellowship 2000, Dr. M.C. Agarwal Trophy, DOS, selected Colonel Regatari Session, multiple awards at AOS and DOS, orations, 3 prestigious orations, and many, many more. I think we don't have time to go through all her achievements.
Let's skip that. Let's skip that. Let's go ahead with what is required. Thank you so much for that lovely introduction. And I'm sure Jatinder Bali is behind it. So naughty guy. Thank you so much.
Right.
I think we should just carry on with what we need to.
Yes, ma'am. So over to you, ma'am. You're talking about
Okay. So the topic,
screen is visible,
am I visible?
Yes, ma'am.
Is my screen visible?
Yes, ma'am.
Visible and audible.
Great. So I was given the task by Dr. Bali, and thank you so much for having me here, and especially in the presence of Dr. Titial, who's been my teacher from the very beginning and a role model. So how to forestall and manage complications to ensure blade longevity. I'm a teacher first and foremost, and all teachers try to keep their students engrossed. And therefore, I will start telling you, collect me with the story. So what's the story? The roads traveled by the cataract surgeon, and you have one of the foremost in India right in front of you, and most of you are cataract surgeons. It's successful. The roads traveled by the refractive surgery, super successful, leads to a gold mine. But the roads traveled by the glaucoma surgeon, all of us know, are fraught with a lot of perils and travel and footfalls. And we have to go step by step in glaucoma surgery to avoid complications if we want the bleb to survive. So let's talk about the story of Little Red Riding Hood. If you remember in your childhood, this lady was there who had gone to see her grandmother, and the big bad wolf came on in the way and tried to lure the child away, and she had to fight for her life. So what does the Red Riding Hood have to fight is that success in glaucoma surgery has 2 wishes. All of us have 2 wishes. That scleral flap heals incompletely and allows aqueous outflow into the subconjunctival space. At the same time, we wish for the conjunctival flap to heal completely without any give. So these 2 wishes are incongruous. They are against nature. Either you have one healing completely, or you have two, healing incompletely. Therefore, because of these incongruous wishes, we have a Laurel and Hardy-like situation. Few of you are youngsters, but the people with gray hairs like me would remember Laurel Hardy of our times. Now, Laurel was the thin guy. So low IOP, shallow AC is very common. It is there's a bleb, poor bleb, it's invariably bleb leak. If it's poor bleb, it also can be choroidals. If it is overfiltering, high bleb with a low IOP and a shallow AC, it's usually overfiltering. Now, there are other differentials also, but these are the common ones in the immediate post-op period. Then we have the Hardy-like situation where everything is very fat and high IOP with normal or deep AC. If it's a poor bleb, it's invariably that your suturing is tight. If it's a poor bleb, it also could be that your sclerostomy is inadequate. If it's a poor or normal bleb, it could be or visco or blood in your anterior chamber. Now, how do you forestall these Laurel and Hardy-like situation is something which is called as releasable suture. And the other aspect is titration for the scleral suturing to make it just right. So this is the Cohen-Osher technique of releasable suturing. You can have whichever one you prefer. You were just shown this technique by Dr. Rakesh right now in a very beautiful video. So, but unlike what he said, I also make a triangular flap, but I try to go for two releasable sutures. So I use the apical suture as the fixed one. And as you can see, I'm going for the two arms as the releasable suture. So the loop is here, and then the fourth row loop is here in one arm, and the other one would be here. Having said that, I always titrate at this point. If you can see, this is the titration for scleral suturing, and you can see that is a pretty much of an outflow of the fluid, and therefore it is necessary that I put one more suture here. If the outflow is not too much, then it is adequate to give a one suture. But invariably, I use a triangular flap, and invariably, I use two releasables and one fixed suture. Now, releasables give you controlled aqueous egress, not a free flow, and they prevent hypotony. It's like a safety net, and you know, as glaucoma surgeons, we are walking always a tightrope between surgical success and failure. And these releasable suture, now this is the Wilson one, you just release them on the slit lamp, and it's very easy to release. Same way you can release the Cohen-Osher on the slit lamp. When do you release the releasable suture? Within 2 weeks usually. If it is mitomycin C use, you can wait for longer. When the IOP is high, definitely. Better than IOP, you don't wait for the IOP to increase. Look at the bleb morphology. So I always tell my resident, bleb ki shakal dekho, akal nahi dekho. If the bleb morphology is flatter, it's not forming with the bleb massage, release the suture then and don't wait for the IOP to rise. The other complication which we very often face is the loose suturing or the bleb leak. Dr. Rakesh showed you very nicely how to have a watertight conjunctival flap. That's very important because if it's not watertight, you'll have a bleb leak or a Siegel's positive. If it's very tight, you'll have a suture-induced astigmatism. So how to get it just right? And remember the Goldilocks story and the three bears. The Goldilocks used the little bear's bed because that was just right for her. And thankfully, in the Mother Earth, we are in the Goldilocks zone from the sun. We are just right. Okay. So how do you go for just right conjunctival or scleral suturing? I showed you the technique of scleral suturing where I titrate. So I'll just show it to you again. Just right. That when you're titrating, now these are the anchoring sutures are already there. The two sutures, as I said, and when I do the titration, now it is adequate. It is not too much of a free flow. And the second thing I always try to do is use a mitomycin C. This can be added on with amniotic membrane. This can be added on with mitomycin C or standalone. It can be used in any age. Mitomycin C, normally I don't use after the age of 50. And this amniotic membrane downregulates the TGF-beta, and it's a very effective antifibrotic agent and a much more safer and a more physiological one. The other just right zone is the conjunctival suturing, and this is the frill incision which was popularized by our team. And this is called the conjunctival frill incision, and we do it 1.5 to 1 millimeter away from the limbus. It's usually 1.5. This saves the limbus stem cells. The integrity of limbus is maintained, and use this running suture or a double on the mattress suture. and you start from one end and you reach the other end. It looks like a smile, and the patient also is smiling. So our residents call it the smile suturing technique, or the sink smile as they call it. And this surgery has been popularized by our center, and we all do it for the last 5-7 years. Here, when you finish the bleb suturing, this is the suturing in the round body 8 nylon. And now if you see, I'm doing the titration of the bleb again, and I'm seeing the bleb forming, and it's a watertight bleb. So so the leak would be very less chance of leaking. The other problem which we often have over time is bleb dysthesias and tear disruption, this bubble formation or the bleb dysthesias. And if you do these titration techniques of bleb dysthesias, and these type of blebs are little infrequent. And this is a clear video of the conjunctival frill suturing again in a different patient. So this is the running suture with a double mattress formation, horizontal mattress. And you take up the slack individually. This is a round body needle, 8 nylon. I don't prefer Vicryl. I know many people prefer Vicryl, but somehow Vicryl and me don't go well together. We are not friends. Vicryl lets me down very frequently. It breaks. The patient may rub the eye, and the conjunctiva of the patients who come to me is very often sick, and I don't trust Vicryl. So I always use steno, and I do use call the patient on the slit lamp again and remove it. So this is the frill suturing, and this is how you remove the conjunctival frill suture after 3 to 4 weeks when the conjunctiva has healed totally, and it's very simple to remove in topical anesthesia on the slit lamp. So cut the one end and pull the other, and it is out. And this has been published before. The other problem is unhappy blebs. Like you do have situations horrendous like this, the unhappy blebs or the very huge blebs, the cystic blebs. And this is usually due to the mitomycin technique, and usually because we have not heard the story of the princess and the pea. If you remember this, the princess, even after so many mattresses, felt a little pea down there. So who is the princess who has to be handled with tender loving care, or TLC? Any guesses? It's a conjunctiva. It requires to be handled with non-tooth forceps, blunt dissection, mitomycin safe Moorfield technique of cutting the pledgets of the mirror cell sponges and pushing them on the other sides so that it's a wide bleb. Wherever possible, add or only use amniotic membrane. And now so many patients are on multiple anti-glaucoma medication, and since the era of the prostaglandins have come in, we are finding in my center over the last 2 decades that over the last 4-5 years, subclinical inflammation and sick conjunctiva is pretty much there. So they do have subconch fibrosis, and we just finished a thesis where we found macrophages, T lymphocytes, and beta lymphocytes were much more in the biopsy of these patients, conjunctival biopsy of these patients. So it's a request that do not wait too long for trabeculectomy surgery. Please remember, all of us are MS surgeons, although AIMS does give us MD, but we are MS and we need to do surgery in time for the trabeculectomy patients to prevent the sick conjunctiva. The other problem which we invariably face is the failing bleb. The bleb does get tired in this marathon which he has to run for the lifetime of a patient. And do remember, bleb massage works wonders, especially in the early phase. It works really very well. Even in the late phase, you can still try it. There is no harm. So what I do is I take the patient in front of a mirror, teach him how to put the finger beneath the eyelid and look up and do the massage. Then I tell the wife or the husband or whoever the caregiver is that cut your nails short and do this for your uncle or aunt or father or husband or wife in front of the mirror for 2 minutes a day, 3 to 4 times a day, and it really works. So first, if the bleb is failing, do bleb massage. In the early phase, if it's failing, do frequent steroids. Having said that, do remember sometimes almost more than 1/3 or 2/3 of the patients can be bleb steroid responders in glaucoma. So sometimes you are giving steroids and that's acting as a double-edged sword. And the other thing, as I just showed you, release the releasable suture within 2 to 3 weeks. Do a sequential release of the first suture first and the second in 2 sittings at a gap of 5 to 7 days. And signs of failing bleb, keep a watch. Tenon cyst forming, walling off of the bleb, reduction of the height of the bleb, increased vascularity, corkscrewing of the vessels, or straightening. Both can be a problem, and IOP may or may not be raised. So bleb morphology is more important than the functionality to see the signs of failing bleb. And whenever you see a failing bleb, always do this test, gonioscopy, to rule out an internal ostium closure, because if this is there, no amount of needling would work. And we are Indians, we have brown, thick irises, and these irises, especially if you've done an inadequate sclerostomy or a very small PI, they do block. In that situation, what we have devised in our center is the internal revision. This internal revision is I go ab interno with a straight instrument, and under viscoelastic cover, I remove the iris which is plugging the ostium, take it out, and from the same side, I go beneath the sterile flap. Then you reform the anterior chamber after draining the viscoelastic, followed by a conventional needling with 5-FU or mitomycin. I invariably prefer mitomycin C unless there is documented toxicity, or if it's a very early stage of failure. In that case, 5-FU may work, and you block the entry side with visco. So this needling really works, and the blocked ostium opens out and the bleb survives. Last, we just talked about the advanced glaucoma. As I said, macular split is, and me and us are friends in our hospital because we see so many of them. We have to avoid snuff out, we have to avoid decompression retinopathy, and we have to avoid malignant glaucoma, which go pretty much hand in hand with advanced glaucoma. So try pre-placed sutures, do a side port creation. I always do a side port. I showed you how to titrate the bleb or the sterile flap, sterile sutures through the side port. And at the end of the surgery also, we put a little bit of visco in the side port or pilocarpine on air to form the chamber. Side port creation, to a slow decompression. You count till 10 when you enter the side port. Always do releasable sutures in advanced glaucomas, and do bleb titration both at the scleral stage and at the conjunctival stage. And you may get away with not having these complications. So as I said, the road is very turbulent, full of twists. Cataract road is all finished when the day you do surgery. Next day, it's a wow factor. Refractive surgeon, next day, it's a wow factor. Glaucoma surgeon, we know that we don't have a wow factor, and we have something like, all of you are familiar with the snakes and ladders games. At any time you can have a fall, and you must remember that between failure and success are these tips of constant vigilance. So you have to make friends with the glaucoma patient. The trap patient is your friend for life, and you are his friend for life, and that is what you have to ensure good compliance and follow up. So if you do all that, the little Red Riding Hood can kick the big bad wolf, and constant vigilance will pick up signs of early failure for a lifelong follow-up of a trap. Thank you.
Thank you so much, ma'am. It was a fantastic presentation. Ma'am, I have a few questions which we've received from people, and I think you're the best person to actually be answering those. You see, it's becoming glaucoma, and in trap, the cataract formation is faster. So if you have a filtering trap, then what exactly are the precautions that the surgeon should take? There's a filtering bleb, and he wants to go in for a cataract surgery. So what are the precautions for the bleb?
So that's a wonderful question, and let me just share with you that we've already been doing with Jatinder and everybody. We are doing something called as Glaucoma Unraveled by Socrates teaching for the last 2 years, and one of the vignettes is a functioning filter. So when you have a functioning filter, you have to see two things. Was it an angle closure glaucoma scenario for which the filtering surgery was done, or was it an open angle glaucoma scenario? And you're doing a cataract for both of the situations. In the angle closure glaucoma scenario, the iris is very often very floppy, and the AC is shallow, and you have this type of a volcano configuration. So you have to put the phaco in a low fluidics, a little bit lower chamber, and even if the iris keeps coming out, forget about it. Do a little PI, reposit the iris, and continue with phaco. Don't keep on trying to reposit it, because it behaves something like a tamsulosin iris, and it just keeps coming out. And when you start the phaco one, before you give the ultrasonic energy at the bleb side, you just put a blob of viscoelastic. If you have Helon, good. If you don't have high vis, 1.5 or 4% also does the job. I just block that area so that the ultrasonic energy is diluted. It still reaches the bleb, It is diluted because the cytokine upregulation is there, and these blebs do tend to fail. Having said that, when you're doing the staining for the cataract surgery, you'll see that trypan blue goes into the bleb area. And from that trypan blue, how it goes, the flow it has, you can make out how good the bleb is functioning. If it's a very nice flow of trypan blue, then you're not worried about the bleb failing. If it is a very small, sticky flow, then you really want the bleb not to fail, and you put this visco blob. For OAG situations, it is a little easier because in those situations, the lens is not so bulky. The cataract surgery is better. Obviously, try to minimize the damage of cataract surgery. Sometimes in ACG, the pupil doesn't dilate, so you may need to have a Malyugin rings or your iris repositors ready. The inflammation is much more in ACG situation than cataract and less in OAG. And if you are finding a bleb is very flat, as I said, the trypan blue dye is not going, it's flat, and you are almost sure that this bleb over the next 2-3 months is going to fail. Then after you've done the cataract surgery, dial the IOL in and put the pilocarpine in. I do sometimes go ahead with the 5FU needling of the bleb on the table. And yes, initially I used to be scared that it will go into the anterior chamber and cause problems. But touch wood, except for one case, we've not had any problems. So because I know, again, these patients may not come back and the bleb will start failing after some time, and they'll come with more damage. So that's the way I use a filtered eye and how to do a cataract surgery with those.
And my next question, I think, is to Professor Tetial. When you have a filtering trap, and what exactly what should we really be thinking about the biometry? Are there any precautions that we need to take with the biometry? And so your take on it, how careful should the operating surgeon be?
Very good point. The biometry can be a difficult sometime in these cases, especially with bleb which are large bleb, hanging bleb, which may cause poor ocular surface also, and your corneal parameter measurements may not be accurate sometimes. So you have to be a little careful in these cases, and maybe one or two repeated examination would be required to ascertain that how much is the actual astigmatism, corneal astigmatism in these cases. The axis of toricity should also be looked into. And if the bleb is all right, it's not really going to make a huge change subsequently. But if your bleb is, overhanging, is large bleb, then it might change the corneal curvature subsequently also. And your surgical results may change in a post-op period. So you have to be little careful, especially looking into a correction of astigmatism, which may be there in these cases. So toric lenses can be planned, and only thing is you have to be very sure that your assessment is accurate in these patients. Second thing, during the surgery also, because most of the times nowadays we all do a temporal surgery. So one of your side port will be, in the superior side. So you have to be little careful not to damage it, the bleb, and make sure your incisions are little corneal without damaging the bleb, or sometimes supporting the globe also. You should be careful. Rather than holding with the, limbs faucet, you might use the, a blunt swab stick which can be supported in these cases. Otherwise, as far as I'm concerned, all these cases would require toric lenses, and they can be implanted very easily.
If I can give one add on to that, that's perfect. That's absolutely correct, sir. Astigmatism is a problem, but even with the trabeculectomy, the axial length would change. So axial length would be a little shorter than pre-trab, but most of the patients don't have the axial length taken during trabeculectomy. So we've made it a habit whenever we do a trab for a phakic eye, we do write the trab, we do write the axial length, so that the surgeon who's going to do a cataract surgery, and as per AGES study, almost 60% of them would require a cataract surgery in 5 years' time. So, but you tell the patient to keep these papers, but most of them don't keep it. So the other way is that you use the axial length of the fellow eye. If the fellow eye has glaucoma but no filtering bleb, that may give you a better clue of what the axial length is. Otherwise, there would be a little myopic, there will be a little shortening of the axial length post trabeclectomy. So that has to be taken into account.
Okay, it's a good point. Like all surgeries, whichever surgery you are doing, you should have a biometry in your hand. You might be doing refractive surgery, you might be doing corneal surgeries. You should have a biometry in your hand. Subsequently, it is always useful when actually you are doing the refractive cataract surgery.
Actually, my question was like, which you'd already answered, like premium IOL, yes or no? So, like,
No,
you already
as
answered
far
that.
as Jatinder, if it is a toric, I don't consider premium nowadays because that's a part and parcel of a refractive correction of a cataract surgery. It is only the multifocal lenses nowadays,
Yeah.
trifocal or extended range of vision, that is a concern. And any patient whose glaucoma, which is going progressive, going to go into advanced phase, all these lenses decreases the contrast sensitivity grossly. So there should never be a choice in these patients, despite their demand. So that is one very clear point,
Yes.
especially if
I
they
think
are
so.
more
Very
than,
well spoken. I think this is the keynote message from this webinar. Actually,
especially if they are more than 2 drugs pre-operatively, they are not a good candidate for these type of lenses. Because all these people have a very poor ocular surface. They're never happy with the multifocal designs. And the optic nerve function as well will be a dearranged in these cases. So even nowadays,
Another thing is many of them will have an irregular astigmatism.
yeah.
So in those situations, even the toric lens will not work really well. With regular astigmatism, sure. Although I haven't much experience because my patients don't afford these lenses, but yeah, they sometimes very often have irregular astigmatism because of that poor bleb and these ocular surface problems. And in those situations, it's kind of better to stay with the safer lenses rather than give them unrealistic expectations, as Sir said.
True. Absolutely true. Sometimes they may require bleb revision, other things to correct. I remember one case where I had to do a DSEC in that patient, post trap patient, and subsequently pressure was so low after 1 week of surgery. I was thinking, what would have gone wrong? Is there some detachment? Corridor detached, something like that. Then we did put a fluorescein, we realized the bleb was leaking so much. And ultimately, patient required a bleb revision and forming the chamber subsequently. So sometimes we don't realize we may be damaging the bleb, which may be thin in a long, prolonged, long duration trap cases. And your surgical insert may be there, which is not visible on the table. Then you realize subsequently bleb has been damaged.
so that's a very
So
interesting
coming back to
question
the
that you.
premium lenses,
Sure.
Yeah.
premium lenses, would EDOF lenses, the extended depth of focus lenses, also be contraindicated?
Personally, if you given choice to me, I'll say yes. Though we are just now doing a study on this also in a compromise patients. We are doing a monovision enhanced monovision lenses, and we are seeing them. But all these EDOF lenses or monovision enhanced lenses are made by changing the spherical aberration profile. So once you change the spherical aberration, in fact, they modify the spherical aberration such they have slightly less in the center. Peripherally, they have more spherical aberration. So you are actually decreasing their contrast value again. So never going to be happy. If anybody who has a compromised optic nerve function, I would go for a lens which gives a maximum light transmission and gives a better focus. So monofocal is the only choice.
Okay. It would be a good idea to do a contrast sensitivity before surgery.
Definitely, yes.
Yes, John Davis, it would be a good idea to do contrast sensitivity. Remember, whichever patient has had a glaucoma filtering surgery means he has had his optic nerve knocked off. And contrast sensitive would anyway be it will be little poor soul right now. So even if you do it, it's going to be little worse off after with aging. Anyway, the optic nerve and retina will be aging, and the contrast will even get knocked off more. So just doing it and thus anticipating it'll remain stable for the next 10 years is unrealistic. So I agree with sir that you want to give a realistic expectation and try to go with the lens which is a maximum light transmission.
Right. Okay, ma'am.
So, with your permission, Professor Tityal, so could we move on to
Please
the...
go on, and I'd like to thank you, Jatinder and Kirti for the invitation. I'll just join you after some time.
Right, sir.
Yeah.
Our next speaker is Dr. Shweta Tripathi. She has done MBBS from BRD Medical College, Gorakhpur, and DNB from Pondicherry Institute Medical Sciences, Pondicherry. She has done her long-term fellowship from the prestigious Shankar Nethralaya, Chennai, from 2010 to 2012, and after which she continues to work at Indira Gandhi Eye Hospital and Research Center, Lucknow, as a senior consultant, where she delivers glaucoma care to her patients. She is Central Zonal Representative for Glaucoma Society of India. She is a regular presenter at international, national, and state conferences in academic sessions and also for delivery of glaucoma skills to the postgraduate and young fellows. She was the organizing secretary for the National Conference for GSI at Lucknow, Glaucoma No, in 2019, and wet lab in charge of Glaucoma Lit at Guwahati. She has many publications to her credit in national and international journals. She will speak on cost effective, minimum invasive glaucoma surgery. Over to you, ma'am.
Is my screen visible?
Yes, ma'am.
So with that, thank you for the kind words, and thank you Bali sir, Tityal sir, and Kirti ma'am for letting me share this platform. So since we have a lot of discussion, I was hearing over the past a couple of minutes, I can say that when we can opt for the different premium lenses when it comes to the glaucoma surgery. So here comes the answer to that particular question. So let's go in detail that actually what is...
Slideshow.
1 second. One second. It's...
Ma'am, I think you need to share entire screen.
I'm sharing it. Now is it okay?
We can see only the PowerPoint, but not the full screen view.
I think
now we can see it. Now we can see it. Yes.
Okay. So, so before we go in the details of this particular, I can say the MIGS or whatever the new is there in the picture or the armamentarium of glaucoma surgery, let's have a look over the burden, I can say the estimated burden as projected by Tham et al. Through this meta-analysis, who said that by 2040, only in Asian countries, approximately 60 million people are going to be suffering from glaucoma. And that's a huge burden. So that means what? That means if we intervene timely with a proper care and a timely, whatever the correct decisions we are making for our patients, definitely this burden, probably we can share our contribution towards the society. So basically in glaucoma, the core concept is all about lowering the pressure, which will halt the disease progression. Also, it will give us a good quality for our patients' lifetime and a good quality for us as operating surgeons also. So going back far in 1960s, when there was the introduction of telephone, or I can say the first man landed on moon, there was a revolution in the field of glaucoma surgery, which came in the form of trabeculectomy by Keynes J. But again, it was said that gradually it became the gold standard in the field of glaucoma surgery. But now, in this changing era, is it really still the gold standard when it comes to from top to bottom for all cases of glaucoma? So now definitely there is a beginning of the new era where when we are talking about a lot of changing the refraction, or I can say the refractive status of the patient through a simple customized cataract surgery, definitely glaucoma field has to offer a lot for the patient. That means the concept of customization and early recovery has been introduced in the field of glaucoma surgeries as well. And how it is? It's with the help of this minimally invasive glaucoma surgery. So since the advances are many, there are many things. But when we talk for countries like us, that is a developing country. So definitely we have to think of some cheaper options, because as Kirti ma'am was correctly pointing out, that not all our patients are going to be affording the premium lenses. Similarly, not all the patients are going to be affording the expensive MIGS procedures. So before we go in that particular detail, let's have a small, fast look that what are the advantages of this minimally invasive glaucoma procedure. So first thing is, we've been talking about the bleb modulation, the bleb, I can say the complications of trabeculectomy, that are filtering surgery. So all this is not there when we talk about the MIGS. Also, it can be performed quickly with a rapid visual recovery. And also, if we tell the patient that the surgery is like going to be simpler, like a cataract surgery, the recovery is so fast, definitely an earlier transition to the surgery can be seen in the patient. So the actual debate is actually when we talk about the against point of mix, that is, it is expensive and the long-term results are awaited. But still, it is a procedure of choice when we come to talk about the customization of the glaucoma surgeries. So these are the results of the different glaucoma surgical procedures. And talking about a case where we have to deal with a coexisting cataract and glaucoma. Talking about the angle closures, as very commonly said, okay, we can go for the filtering surgeries. But yes, the role of MIGS now cannot be denied in the field of angle closures as well. So let's talk about the very beginning of the angle surgery, especially in an angle closure eye, where we see that how the GSL combined with the cataract surgery in an advanced case with a baseline pressure of 30, the pressures came out, to our surprise, to 10 millimeters, which the patient is still maintaining after 1 year of surgery. So this was an old gentleman who underwent phaco-IOL with goniosynoequalisis. So this is what we did, is that after doing the cataract surgery, now since we have been talking about the astigmatism, there should be a precision in the corneal entry wound as well. Making a 6 millimeters rhexis because the cataract was hard. Performing the cataract surgery. And now after that, after we have inserted the IOL, a high molecular weight viscoelastic is injected into the AC and it is placed over the corneal surface as well. And now the placement of the Swan-Jacob lens is placed over the corneal surface. You visualize the angle. No bubble should be there, because the bubbles, like in OPD, they hamper the view. Similarly here. Now with the help of the cyclodialysis spatula, there's a tweak motion which is made in the angle. As we can see. Now again, we have to avoid the corneal folds, as we can see that it is obscuring the view. So now you can see that there is a swiping motion and a tapping motion. And that way, we release the synecdoche. Again, a replay to the same procedure in a magnified view. It's a very simple procedure which can be combined most of the time with the surgeries, and especially when we plan to start a angle surgery, this can be taken as a step 1. This is a swiping motion and a tapping movement. And this is how the synecdoche is released of this particular case. Now the AC is washed, because since we have fiddled with the angle, so there is so much of hyphema. And at the end of the surgery and at the end of 1 year, the pressures were 10 and the patient was quite happy because of the early recovery. So we say with the help of the literature, so definitely the minimal invasive glaucoma surgeries, they do have a promising role in cases of angle closures as well. Now coming to the most talked about surgeries, that is the cost-effective surgery, which our normal patients can afford, and we can also do it comfortably when we are planning a cataract surgery, even with a premium IOL. Because first of all, the case selection in these particular cases are mild to moderate glaucoma, where the patients are only on 1 or 2 drops, and the disc damage is also not to the advanced condition. So this is a case of a bang where after the insertion of the IOL, in a magnified view of the angle, we can see that the angle structures are very clearly visualized. Now what you do is that with the help of a 24 or a 25 gauge needle, you just simply excise a portion of the TM in certain clock hours. Here, it goes, it strikes off, and you peel off the TM. And with the help of the fossil, you can even pull it off so that later on, there is no occlusion of your angle per se again. Now, again, a second case where after the insertion of IOL, the only key to success for this angle surgeries would be, and I can say the stepping stone also, a well understood concept of intraoperative gonioscopy. See here that how beautifully the needle is excising the TM. We have excised it, and now in a magnified view, we can see that the portion is there, which with the help of this faucet, we are taking out. And the pressures are well controlled after the surgery. So now, as we talk about the future scenario, as we say that the matches are made in heaven. So out of all the surgical options in the angle surgeries, definitely for a developing country, we are looking for a best option, which could be in the form of a BANG, that is bent ab interno needle goniectomy. With that, I can say that ultimately it is the surgeon who is going to decide which surgery to perform, the risk profile of the patient's eye, the stage of the disease, and the first and the foremost thing is that always counsel your patient that he might need a trabeculectomy later in life. So as I can say the father of MIGS, Aiki Ahmed, says that MIGS devices are designed simply to address the gap that exists between the medical therapy and the aggressive traditional surgical options. Thank you very much.
Thank you, Dr. Tripathi. I think that was a fantastic presentation. Definitely, MIGS is coming up in a big way. But we need to remember one thing, that historically it has been proved that if your patient selection is correct, and if the surgery is performed correctly, then the trabeculectomy has given the results the most consistent maintenance of the intraocular pressures over an extended period of time. But yes, definitely MIGS is coming up in a big way, more so, because we're looking at combined mechanisms and of addressing the problem. And given the fact that you're combining it with the phaco procedure directly, like with the lens extraction, I would like to know your this thing on it.
Definitely, as you said very correctly, sir, that the case selection. As we talk about the case selections with advanced cupping, definitely in those particular cases, we cannot take the chances with MIGS. But of course, when you know that the patient, as we've been talking about the ocular surface, that the patient's ocular surface is being compromised with the use of AGM for a longer time, or the patient doesn't want to go for I can say filtering surgery, because there is a lot of manipulation we need to do to revive the bleb, to make the bleb keep surviving. So all those things can be bypassed when you talk about a case where there is a mild to moderate cupping. The patient is on a single or two drugs, and the patient wants that early recovery like a cataract surgery. Because in cataract surgery, we see the case on the first day, 7th day, and that's all 30th day. We give the glass prescription and the surgery, and the story gets over there. Similarly, and the patient is happy, and so are we. So since I have started doing banks, even my patients who are having advanced cupping, they want that surgery to be done for them. So I am the one who is demotivating them that no, please go for trabeculectomy. So simply the case selection plays the most important role in this particular angle surgery, sir.
That was just a caveat rather than, because it looks very attractive that I have a needle, I'm going to just push it into the it is not easy. You have to be very conversant with the anatomy of the angle. And
Yes.
B, do you like the tissue that you take out, do you get histopathology or something of
No, not
no.
yet, but I am thinking of it, because we can do, I'm thinking of doing a study on that, taking out that portion of TM and then doing it for histopath.
Great.
Ma'am, what
Any
block
other
do you-
observations? John wants to say something.
Do you do it at a peribulbar or subtenon's block, ma'am?
No, I do it in a proper peribulbar block only, not subtenons.
Okay. Okay. Patient eye movement has to be completely.
Yes, because when you are tilting the head, you are tilting the microscope, you're doing everything. So much of manipulation is there. So if the patient is not comfortable and he shakes the eyes, then definitely you might land up in some other structure that may cause so much of bleed that it is difficult sometimes to manage.
And
Ma'am, and what gauge needle are you using for band?
For 25. Though we don't
25.
get it in India, so 25, I have procured it from somewhere else abroad. And otherwise, if you don't get that, you can go ahead with 24 as well.
Okay. And you're bending it backwards.
Yes, it's like you make a cystitome, no? So a little modification in the cystitome, like you make a cystitome kind of thing with a longer needle, longer tip. And along
But
with
it's
that,
not shaped like a Cahook dual blade.
No, it is not. No, it is not. Yeah.
No, it's not-
Actually, what happens is there's an incision thing that is happening. Kahuk is, it is holding it up and stripping along two edges. So Kahuk
Right.
is.
If you fold it this way, the other two edges are also there, but they are curved. They don't come in the correct angle.
Yeah.
So I guess there is no point in folding it in the opposite way to a cystitome. Okay.
No. And actually, you can just peel it off also. Like this KDB, no, they peel off the TM. You had seen that. Sorry, actually, in the background, my dogs are barking. I'm so sorry for that.
No, not an issue.
Yes.
See, in the Kahuk, there are two ridges there which are going to raise and cut it from there. And the leading edge is raising it and pushing it. And then you get that strip. So you were saying something about that?
So because because there was in my second video, that's why I magnified the view, because even TM was excised in that particular portion and I could take it out with the forceps. So definitely you can do that with not a, the way the needle is been I can say made into a cystitome, again you have to make a S kind of thing. So it causes the easy manipulation in the angle. That is really important.
Okay. And have you had any issues with hyphema and inflammation, ma'am?
No, actually, there was only a young person who had hyphema on the next day. He was a steroid responder, steroid-induced glaucoma. So I had to do a combined surgery for him, this bang along with the IOL insertion. Next day, I could see some hyphema. But actually, he was hypertensive as well. And the hyphema resolved on the second day of post-op. Like Saturday,
do you pressurize the chamber for some time after surgery?
Yes. Yes.
Okay.
Because see, when you are fiddling with the angle, no, definitely there is a tendency that it will bleed. See, in my GSL case also, there was so much of bleeding, but everything vanished off on the first post-op day. But only one case I had so far who had 1 millimeter of hyphema on post-operative day 1, which resolved on POD2. So definitely it's not nothing to be worried about.
Thank you, ma'am.
Mr. Rahul, can we have the video, please? That was a nice presentation, ma'am. Swati, are you there? I think we'll go on to the next speaker. Rahul, we would love to have the video, yeah? Okay, fine. I think...
Okay. I'll introduce Dr. Prachi. Okay. Yes. So Dr. Prachi Grover is the next speaker. She is the founder director at Prabhat Eye Care. She's a phaco-refractive and glaucoma consultant at Delhi NCR. Has done a comprehensive glaucoma fellowship from SNC Chitrakoot, phaco trabeculectomy and AGV instructor at SSTCs, instructor at International Society of Manual Small Incision Cataract Surgeries, and has presented various papers at state, national, and international conferences. She has been faculty, panelist, and judge at various conferences, and she is the recipient of Women for Social Change Award at Women Ophthalmologists Society Conference. So over to you, Dr. Prachi, for your topic, glaucoma management in pregnancy.
So good evening, all. Thank you, Dr. Bali, sir, for having me here. It's honor to share the screen with my ex-HOD, Dr. Shakya, sir. So I'll be speaking on glaucoma management in pregnancy. So when we have a glaucoma patient in reproductive, is my screen visible?
Yes, yes.
Yes.
Yes, ma'am.
Full screen, I think.
So
but it's not got into full screen yet.
It's not gone into a slideshow mode as yet.
Slideshow.
The play is not there.
I guess you have to stop sharing and share full screen again. Share entire screen. Yes. This should work. It is visible, but not full screen.
I don't know what to do.
You can escape and probably do it again.
Is it okay now? Is it okay?
It is not full screen yet. I think you can play.
Okay. So when we have a glaucoma patient in a reproductive age, we are in a dilemma what to start with or what to continue, whether we move to the surgical option or laser. So here I'll be discussing all these things. So there's a frequency of glaucoma around pregnancies on the rise because of a glaucoma detection at younger age is increasing due to the more improved glaucoma diagnostic tools and pregnancies at an advanced age due to the newer reproductive technologies. So if the pregnant patient without glaucoma, generally the IOP lowers because of the increased outflow and decreased production, but it comes to baseline at the 6 weeks of postpartum. In normal vaginal delivery, there's no significant IOP fluctuation, but in cesarean, there's a slight increase in IOP. So pregnant patients with glaucoma, already pre-existing glaucomas, IOP generally decreases, but few literature have reported there's a increase in IOP with worsening of IOP control and visual field defects. So we have to increase the surveillance in the patients with a family history of glaucoma. So recommended follow-ups are at 1 to 3 months. But there's a unique challenge of we have to balance between the risk of the vision loss to the mother and the potential harm to the fetus. So we have 3 options of IOP lowering. I'll be discussing one by one. So coming to the medical management, like prostaglandin analogs, The older prostaglandin analogs stimulates uterine contraction, thus producing premature labor or even miscarriages. And latanoprost, it has seen with a lower birth weight. And the newer prostaglandin analogs have no human data but have been reported as fetal toxicity in animals. So coming to beta blockers, oral
may
beta
I
blockers.
interrupt, Dr. Prachi? I
Yeah.
think you can go press the play button on the top and select play slideshow not in window.
Okay.
The
I
third
think
last
I'm-
option. In the top,
Is
on
it-
the top of the whole screen, on the top of the whole screen, the third last option.
Okay.
Yes, yes. Here, I think you can just stop play and then play. Currently, it's playing in a window, in a small window, so it's small for us. Just stop this, stop the presentation, and go to play on the top. Just open the presentation again, and when you're about to play, just play full screen, not in window. On the very top.
Yeah. Is it okay now?
Yeah, now it is full screen. Yes. Okay.
Shall I resume it or?
Yeah, please.
Okay. So in coming to beta blockers, so oral beta blockers given close to delivery, it may cause fetal or neonatal bradyarrhythmias, hypotension, hypoglycemia, even respiratory distress and apnea. Topical beta blockers, these are the first line of drug in second trimesters. So brimonidine is the safest option, but we have to stop it near the delivery because it may cause CNS depression and apnea in newborns, and it is contraindicated in infants and children up to 10 years. So topical carbonic anhydrase inhibitors, torzolamide, it has seen that it leads to the malformation of vertebral bodies in rabbit during pregnancy. So brinzolamide is a better alternative, but and oral acetazolamide, it is absolutely contraindicated in first trimester, can be given with caution in second and third trimester, but we have to assess the risk versus benefit ratio. So pilocarpine, it is a teratogenic in animals, and systemic parasympathomimetic drugs, in first 4 months, there are no congenital anomalies are seen, but near the term, neonatal hyperthermia, restlessness, seizure, diaphoresis, or mimic the signs of meningitis. Mannitol, glycerol, there are no studies. Newer drugs, nitazoxanide, there are no human studies, but in rabbit, it may cause adverse effect. So to summarize, it's like in the first trimester, safest option is brimonidine. And we have to avoid beta blockers, PGA, CAIs. In second trimester, we can continue with the brimonidine and beta blocker, but we have to monitor regularly the fetal heart rate and fetal growth monitoring. In third trimester, topical CIs may be the optimal choice, but we have to stop it in the last month of pregnancy and in lactating mothers. So coming to role of lasers, SLT and ALT can be safe and effective. It can be used in all the trimester, but the effect is short-lived, but the most accepted first line of treatment during pregnancy and lactation. So coming to surgery, when to do surgery? Either before conception, in uncontrolled advanced glaucoma, or either after second trimester to reduce the potentially teratogenic effects of anesthetic agent, and you have to avoid the anti-metabolite use. So surgical options may be filtration surgeries or glaucoma drainage devices or newer MIGS surgery. So a filtration surgery, but there is an issue of higher chances of risk of failure because of the younger age or physiological changes during the pregnancy, or we have to anti-metabolites are contraindicated, and there are chances of tissue edema, which makes the suturing difficult. So, and coming to the valvular devices, they are the alternative to treat refractive glaucomas, and newer MIGs may be safer and effective. But there are few challenges in the surgery. There are the problems with anesthesia, positioning for the surgery, potential risk with antimetabolites, and concern with the post-op complication management. So coming to anesthesia, general anesthesia has fewer risk of hypoxia, hypercapnia, hypertension, lower birth weight, and fewer reports have shown a neural tube defect. Local anesthesia, but only the preferred technique is subconjunctival or anterior subtenon anesthesia with a topical anesthesia. So positioning, there is a difficulty with the supine position in the second and the third trimester. This may cause compression of the aortal or the vena cava compression, which may lead to profound hypertension. But during the surgery, we have to intraoperatively monitoring the fetal heart rate monitoring to prevent fetal complications. So post-operative precautions, topical antibiotics, we have to be careful about that. Topical steroids, prednisolone and methylpred may cause the placenta, but less than betamethasone or dexamethasone. Hometropine can be used. It is less likely to affect the fetus. Atropine should be avoided. It may cause fetal bradycardia. So do's and don'ts for the patient, like we have to explain the patient about the punctal occlusion and eyelid closure and avoid blinking. So for the lactating mothers, topical carbonic anhydrate inhibitors and PG are generally considered safe. We have to discontinue brimonidine, avoid beta blockers with lactation, and use of systemic carbonic anhydrase inhibitor with caution to prevent renal or hepatic effects in the infant. Advise mother to breastfeed the baby just before putting the drops, and if surgery is required, we have to immediately take the patient after nursing, so to avoid significant concentration of anesthetic agent into the breast milk. So to conclude, address childbearing plans, patient, obstetricians, neonatologist should be involved in the process, and the safest agent, minimal effective dose and the duration should be considered. Laser trabeculoplasty is a safe and alternative adjunct. Surgery, if required, is best performed before planning pregnancy or in the second trimester. Thank you.
Thank you, Dr. Prachi. That was a fantastic presentation. Actually, it is a very big topic, and it is very difficult to cover it in 7 minutes, 9 minutes. What do you say, Dr. Shweta? You've done a fantastic job of it, actually.
You're muted, ma'am.
You're muted, Dr. Shweta.
Dr. Shweta, you're muted.
Yeah, so I'm saying she's done a wonderful job. She has concised everything under one roof, and a very nice presentation.
Thank you, ma'am.
Actually, we are waiting for that corporate video to be played by Mr. Jan. Mr. Jan, are you there? Actually, we need to have a bigger session talking of focusing more on pregnancy. So we are thankful to our sponsors. Good enough. How do you come to know when it's finished? Great. So I think it has been a fantastic evening, and I want to thank all the speakers, the chief guest, all our panelists, our moderators, for sparing their time on this evening, especially when you had so many things happening, and it's been a very eventful evening. We've already overshot our time limit by around 20 minutes. So I think with the permission of the chief guest and Professor Kirti and all of you, I think we would like to draw this meeting to a close. Are we agreed?
Definitely, we agree to that. So it was a wonderful discussion tonight and a very nicely moderated session as well. And we look forward many more like this.
Thank you.
Thank you, everybody, and good night.
Thank you, everyone.
Thank you.
Good night.
Good night.